everyone. So today we are going to study about the anti-tubercular agents. So anti-tubercular agents are nothing but the drugs or agents that are used in the treatment of tuberculosis. So what are tuberculosis? It is a potentially serious infectious bacterial disease which mainly affects the lungs. That is, the target organ is lungs. The bacteria that causes TB are spread when an infected person sneezes, coughs, or even talks. Most people infected with bacteria that cause tuberculosis do not have symptoms. When symptoms do occur, they usually include cough, sneezing, okay, and while coughing there is bleeding. All right, and also which the symptoms do occur, they usually include the cough and weight loss, night sweats, and fever. Now, the treatment isn't always required for those without symptoms. Patients with active symptoms will require a long course for the treatment involving multiple antibiotics. So, those with the tuberculosis require multiple antibiotics and are kept on the treatment for a longer period of time. So, let's see the classification. So generally in the classification, it is classified according to the clinical utility of anti-TB drugs, that is first line and second line. Okay, so first line, these have the high tubercular efficacy as well as the low toxicity, and they can be used as routinely drugs. And second line may you have low anti-tubercular efficacy, they are having very high toxicity or sometimes both, and they use as a reserve drugs that are just given on the premium basis, like, okay. And routinely drugs are classified as a first line anti-TB drugs. Moving ahead to the first line drugs, the first line drugs, very important first drug is isoniazid, okay. Then we have the second important drug rifampin, pyrazinamide, ethambutol, streptomycin. This is nothing but the category of your antibiotic. Now isoniazid H, it is symbolized as H, rifampin R, pyrazinamide Z, ethambutol E, and streptomycin S. So you can also remember like this, Herses, okay. Herses, like you can remember, and this is generally the symbolized given in the clinical terms. So moving ahead to the second line drugs. Second line drugs, you have ethonomide, prothionamide, cycloserine, terizonide, paraminoxalisalic acid, thiaacetazone. Injectable drugs may we have kanamycin, amikacin, capreomycin, and fluoroquinones may we have ofloxacin, levofloxacin, moxifloxacin, ciprofloxacin, and rifabutin. So let's move ahead. So now we have alternating grouping of antitubercular. So I have classified here as 5 groups. First is first line oral drugs, injectable anti-TB drugs. So oral drugs may generally isoniazid, rifampin, pyrazinamide, and ethambutol are given orally as in the form of the tablets. Injectables may streptomycin, which is an antibiotic, kanamycin, that is nothing but an aminoglycoside antibiotic, amikacin, and capreomycin. Then in fluoroquinones, we give generally the anti-allergic drugs also, that is ofloxacin, levofloxacin, ciprofloxacin. Then second line, this was about the first line oral drugs. Then the fourth group is second line oral anti-TB drugs, in which we have ethinomide, protonamide, cycloserine, para-aminosalicylic acid. This is to remember, this is PAS, para-amino salicylic acid, okay. Generally it is written in the short form like this. And drugs with unclear efficacy, we have the antibiotic clarithromycin, thiaacetazone, clofazimine, linezolid, amoxicillin, clovunate, imipenem, cilastatin, okay. Now these are adopted from these grouping of antitubercular drugs are adopted from the treatment of tuberculosis guidelines given by the World Health Organization 4th edition of 2010 and revised National Tuberculosis Control Program RNTCP DOTS plus guidelines 2010. and generally this symbol is not recommended by WHO for routine used in the MDR TB. So which is the drugs with unclear efficacy. So these are not the drugs that are generally prescribed or recommended by the World Health Organization. They are just routinely clinical medications that are given to the person. So group 1, as we all know, these are the first line oral drugs, anti-TB oral drugs. So these are the most potent and best tolerated oral drugs that can be used routinely. Please make sure of the words routinely and reserved. Second line drugs may you will see the word reserved, and in group 1 that is your first line drugs, you will see the routinely. Group 2, again you have the injectables. So they are protein bactericidal, okay, that generally include the antibiotics, okay, but they are just given in the parenteral form. Group 3, which includes the fluoroquinolones, which are well tolerated to the bactericidal oral drugs, and all patients with a drug resistant TB should receive one fluoroquinolone. So as due to the intake of the TB drugs on the frequent basis, there might be any patient who in whose body the resistance may be created due to the drug. So in this case, the fluoroquinolone should be given to each every person, at least one, okay, like levofloxacin, ofloxacin. Levofloxacin is generally given, okay, which is nothing but the racemate mixture of your ofloxacin. Group 4 is less effective, bacteriostatic, more toxic. This is the second line drug, okay, that was with the more toxicity and low efficacy, okay, and they are used as the reserve drugs for resistant TB. Group 5 are drugs that are with uncertain efficacy and not recommended by the MDR-TB may be used extensively in the resistance of the TB. So generally the second line drugs are prescribed when there is any kind of resistance created in the body due to the anti-TB drugs. Next, we have the first line drugs which we discussed. We will see the mechanism of each. So let's move with the first drug, that is isoniazid. Isoniazid is also known as isonicotinic acid hydrazide. Okay, you can see you just have the, if I go into the chemistry, you can see you have the hydrazide like structure and the this carboxylic like CO derivative. So it is nothing but isonicotinic acid hydrazide, which is an excellent antitubercular drug and is an essential component of all the antitubercular regimens unless the patient is not able to tolerate or the bacilli has created some of the resistant. It acts generally on the extravascular as well as intracellular TB, which is present inside the macrophages and equally active in acidic or alkaline medium. It is one of the cheapest antitubercular drugs. So generally you all can write if the answer comes about the isoniazid. It is generally an excellent antitubercular first line oral drug and it is one of the cheapest drug. It acts on extracellular as well as intracellular TB, wherein the bacilli is present within the macrophages and is equally active in any of the medium, that is maybe acidic or alkaline. So this is generally the mechanism of isoniazid. Isoniazid works by inhibiting directly the bacterial cell wall synthesis. So isoniazid, in the presence of mycobacterial catalase peroxidase, that is CATG, is converted into an active metabolite which leads to the formation of covalent complex with ACP reductase and beta ketoacyl ACP synthase, which leads to the inhibition of mycolic acid synthesis, and this will inhibit the formation of mycobacterium cell wall. So this is generally how the isoniazid works, by converting itself into an active metabolite which forms a covalent bond with the ACP reductase and generally the enzymes and beta ketoacyl ACP synthase, and that leads to the inhibition of mycolic acid synthesis, which is an essential component of the mycobacterium cell wall. So just it and in this peptidoglycan layer is generally also involved, okay, and which leads to the inhibition of the formation of the microbacterial cell wall. Pharmacokinetics It is absorbed orally and penetrates into all the blood tissues. Uh, Cavities like tubercular cavities, placenta, and meninges. It is extensively metabolized in liver and most important pathway for being the N-acetylation by NAT2. The acylated metabolite is excreted in urine and the rate of isoniazide acylation shows genetic variation. So generally when the isoniazide undergoes into its metabolism, it is converted into three important products, that is N-acetyl isoniazide, nicotinic acid, and your acetyl hydrazine. Now, acetyl hydrazine is itself is a product of N-acetyl. Okay, and this is generally metabolized with this enzyme that is nothing but N-acetyl transferase. Okay, and then you get the active metabolite which is excreted via urine. Okay, and generally the acetylation reaction occurs, which you all will be covering in your medicinal chemistry part. So interactions, aluminum hydroxide inhibits isoniazide absorption. So generally it counter interacts with the antacids. It also retards phenytoin, carbamazepine, diazepam, theophylline, warfarin metabolism by inhibiting the CYP2C19 and CYP3A4 and may raise their blood levels. Since rifampin is an enzyme inducer, it is concurrent use counterintelligence the inhibitory effect of isoniazide. Yes, we all know if the isoniazide and rifampin is given, as we all know if rifampin is an enzyme inducer, it will again counter interact the inhibitory effect of isoniazide, and however the net effect of the metabolism of many drugs is unpredictable. Paraaminosalicylic acid inhibits the isoniazide metabolism and prolongs its T half-life. Adverse effects: it is well tolerated, peripheral neuritis and variety of neurological manifestations like paresthesia, numbness, mental disturbances, rarely convulsions are most important dose-dependent toxic effects. Hepatitis is one of the major effects of isoniazide, and also due to the acetyl radical formation during the metabolism, it can also lead to a severe hepatotoxicity as an adverse effect or the hepatitis. Okay, because whatever the N-acetyl radical is formed, it acts as a substrate in which it acts in the cell necrosis of the liver. Okay, and in children it is rare, but it is common in older and the people in alcoholics, like the people who generally consume alcohol in large numbers. Okay, and large quantity. Other side effects are lethargy, rashes, fever, acne, and other allergia. Then the next drug we will be covering is rifampin, that is nothing but a rifampicin R. It is a semisynthetic derivative of rifam rifampicin B obtained from the Streptomyces mediterraneae. Okay, this rifampin is a bactericidal to the M. tuberculosis. Bactericidal is nothing but it shows a killing action towards the tubercular bacterial bacilli and other gram positive and gram negative bacteria. So we are talking about the rifampin, that is nothing but rifampicin obtained. It is a semisynthetic derivative of rifampicin B, which is obtained from the Streptomyces mediterraneae. Mechanism of action: rifampicin binds with the beta subunit of DNA dependent RNA polymerase, inhibition of mRNA synthesis, and shows a tuberculosis effect. It cannot bind to human RNA polymerase, thus selectively destroying the bacteria.